I, Dr. D. Ramurthy, have the pleasure of welcoming you to the Eye Foundation group of eye hospitals. What started out way back in 1983 as a single-man clinic is today spread across almost 2.5 lakh square feet across 8 different locations in the cities of Coimbatore, Tirupur, Ooty, Mettupalayam, Kochi and Bangalore. It is our constant endeavor to offer state-of-the-art eye care to the entire gamut of eye diseases, be it cataract surgery, corneal diseases, eye transplantation, vitreoretinal disorders, oculoplasty, ocular trauma or glaucoma. Equipped with the latest in armamentarium, we truly are in a position to offer world-class facility to each and everyone who comes to us. We are aware of the fact there are costs involved in providing this kind of high care technology, but it is our constant effort to keep the cost at bay so that every patient who approaches us for his or her treatment is taken care of. Our focus has always been patient-centric, and in this effort, I am aided by a group of 40 highly trained, motivated ophthalmologists who are backed up by 400 odd professionals who have a common vision of satisfying the patients at every turn.
About 14 years I used specs. Now I did my LASIK according to my doctor's suggestion. It's feel better now. I'm doing my regular activities comfortably. I'm a basic bike stunter. First of all, while stunting, my specs is an obstacle for me while removing helmet and placing helmet. Now it's fine and easy thanks to Eye Foundation.
Refractive surgery was something which was unheard of a little more than 2 decades back world over, and it came into inception about 2.5 decades, and we were the second in our country to have embraced this awesome specialty called refractive surgery. When we talk of refractive surgery, we mean refractive correction, that is correction of the refractive error of the eye. That is what you would colloquially call the minus power or the plus power or the cylindrical power, which has to be corrected either with glasses or with contact lenses. Now, in the domain of refractive surgery, what we do is once a person is 18 years of age, which is when the growth of the body and the eyeball is structured and the progression of the refractive error is complete, is when we decide that these are the ideal candidates to undergo a refractive procedure. So once a person at the age of 18, does it mean every single person at the age of 18 is eligible for refractive surgery? No. First, he needs to have a refractive error, a minus, plus or a cylindrical power. But over and above, he has to be a normal candidate to undergo a refractive procedure. We say that we can do the procedure from 18 years onwards, but even a person at the age of 40 can undergo a refractive procedure if he has missed the bus at the age of 18 and 20 when he could have very well got it done. Now these are patients after 40, you need reading glasses. So how we would advise for them is called a monovision treatment, wherein we would give a full correction in the dominant eye for distance and undercorrect the other eye, so that gives him ease for reading. So this is how we would deal a 40 plus person, whereas 18 years of age onwards, we would give a full distance correction. So what next question is, how would you deal with a patient who decides to get refractive surgery done at my hospital? So let's assume that the patient wants to gain some information. He could come to our reception desk and ask that we are interested in getting a laser vision correction. How do we go about it? Or there could be a few who would call on phone, or some who would go online and get onto an email ID and want to collect all these details. So we have a refractive surgery counselor who deals with all these queries of a patient. So whenever a patient comes with this doubt, they are led in person to the counselor or talked to on phone or given a detailed information as far all that is relevant to him about the refractive surgery. So then once this amount of information is taken on and the patient decides that they want to go in for the procedure, they take an appointment and are made to see the respective areas. So how does the examination go about? We would first take him on to the refraction cubicle, where a very good optometrist who is specially designed for a detailed refractive evaluation takes on this patient, who does a complete thorough refraction of the individual, and then sits back and explains to him that he is an eligible candidate for refractive procedure. So the next evaluation is doing a topography, wherein the patient is led to the topography room, where it's an array of machines where we do the scan of the cornea, and we do it on the very different latest technology which is available. That is the pentacam, and then we go on to measure the corpus or the biomechanical strength of the cornea. Then we have an aberrometry, wherein we measure what are the higher order abrasions in the cornea. So essentially all of these collectively give us an information whether this eye is eligible for refractive surgery, and gives us an idea as to which option we should decide for. So what is the very latest which we have in the laser vision technology is called the Relax Smile procedure, wherein it was understood that if you do not create a flap at all, if you could just make a smaller incision, just 2 to 3 millimeter incision on the cornea, and if you could fashion a lenticule with the femtosecond laser, the thickness of the lenticule and the shape of the lenticule would take care of the refractive correction of the eye. And if you could remove that lenticule through this small pocket incision, and then by therein itself you would have reshaped the cornea and done the refractive correction. That is, it becomes an all-in-one solution, wherein under Visumax laser or a femtosecond laser platform, what is done is the lenticule is fashioned on the femtosecond laser and a small incision is created, and this lenticule is removed. So there is no role of excimer laser or its vagaries, and you are in one platform itself. You are able to do the creation of the lenticule and the removal of the lenticule and the refractive correction of the patient. So then it promised greater advantages, greater biomechanical stability for the eye, a smaller incision. If you are cutting a flap, you are cutting more nerve endings. However, all these nerve endings regenerate over a period of 6 weeks to 3 months to 6 months, or a little more to a year. But all that you need is to just keep them going on artificial tears in a tapered fashion. Whereas being a small incision surgery, you are able to obviate the need of artificial tears to a larger period. And because of the promises of biomechanical stability and a great visual performance, Smile became the next leader in this laser vision correction platform. However, what we always need to understand is surface ablation has its own particular area in a thinner cornea with a power of less than -6, when you could do only surface ablation on the eye. If you have a person could opt for a manual microkeratome or a femtosecond laser flap if he has a higher refractive error than what Smile could correct, or if the economics of the procedures which make him choose that option, or he would go in for Smile if all the parameters needed for a Smile surgery are covered, or if he has a higher refractive error, he would go in for an eye seal surgery. If he has a little weaker biomechanics, each of these procedures would be combined with cross-linking when you call it as LASIK extra or PRK extra or a Smile extra procedure. Now, once all these things are done and the procedure is done for the patient, post-operatively, the patient after a couple of hours or 3 hours of mild watering is absolutely fine, and the next day is quite cheerful and happy. He can go back to his day-to-day routine. However, the patient is told not to touch his eyes, is put on few drops, and of course artificial tears which continue for a period of 6 weeks to 3 months to 6 months. And more so depending on the professional need, wherein the amount of or the temperature the place, the need for artificial tears could be for a little longer period. But definitely the visual rehabilitation is complete, and these are a group of extremely happy patients. Having discussed the different options which are available and some basic understanding of the pre-op evaluation and the post-operative course, what is most important to understand in a refractive surgery patient is that all of these patients need to have a regular follow-up, as they would if they were wearing glasses, because there is an important thing called a retinal examination which is done, a thorough retinal examination which is done for all these patients once a year. So it does, just because you we've got him rid of his spectacle correction does not mean that he walks off forever out of an eye hospital. He needs to keep coming back on a yearly evaluation and gets his eye evaluated. And our follow-up is such that we call the patient the next day, after 6 weeks, after 4 months, wherein repeat the topography to see whether the scan is quite normal, do a complete retinal evaluation and advise the patient to come for a yearly evaluation. And a word about a patient above the age of 40, which I had already alluded to. Even at the age of 40, unless he's developed a very early cataract, wherein we would do the requisite correction to get him vision free of glasses. In this particular age group, we could do what is a monovision treatment, wherein we would correct one eye, which is a dominant eye, for a distance, and the other eye we would undercorrect so that it allows him the ease for reading and thus take care of his visual needs at that particular age too.
மேலும் எனக்கு இங்கே ஊழியர்கள் மிகவும் அன்பாகவும் சிறப்பாகவும் கவனித்தார்கள். உடனே எனக்கு சர்ஜரி பண்ண உடனேயே நல்ல முறையில் பார்வையும் எல்லாம் தெரிந்துவிட்டு நல்ல நிலையில் நலமாக இருக்கிறேன் என்பதை மிகவும் அன்போடும் வணக்கத்தோடும் தெரிவித்துக் கொள்கிறேன்.
Cataract surgery is the commonest surgery performed in the human body. In India, we perform almost 6.5 million cataract surgeries, which is more than the total number of cataract surgeries performed in United States, China and Western Europe put together. What exactly is cataract surgery? All of us have a lens which helps us to focus the light onto the back surface of the eye, which is the retina, where the image of what we are seeing is formed. When this lens, because of age, opacifies, that disrupts the light from passing into the eye, and that is what is called the cataract. And in this cataract surgery, what we are doing is to remove this cataract through an extremely small incision and implanting a clear artificial lens inside the eye. Previously, we used to perform cataract surgery with a very large, almost 9 to 10 millimeter incision, and which required sutures to close up. But today, we are doing this surgery with a small 2.2 millimeter incision using a technique called phacoemulsification. In phacoemulsification, we use ultrasound to pulverize the lens to extremely small bits and subsequently sucking this out. Once the capsular bag is emptied out of the opaque lens material, we implant a foldable intraocular lens, which is overall diameter of 13 millimeters, but since it's folded, it goes in through a small 2.2 millimeter incision inside the eye where it opens up. And because we are replacing the opaque lens material with an extremely transparent intraocular lens, once again the eye regains the power to focus and see objects clearly. Phacoemulsification has of course been a boon, a great development in the field of ophthalmology, and it has modernized cataract surgery, reducing the size of incision from 13 millimeters to just about 2 to 2.2 millimeters, because of which there is no sutures that are placed. In eye foundation, we do not give any injections. The entire surgery is done with drops alone, and subsequently the patient is allowed to go home within a period of 3 to 4 hours after the surgery. The patient walks into the hospital in the morning after a good breakfast. The surgery just lasts for about 8 to 10 minutes, and then they are allowed to go home when they can return to almost all their normal activities, be it watching TV, reading books, working on computers, doing household chores, cooking, or even traveling. At best, they are asked to put cooling glasses for a period of about 1 week and restricted from splashing water in the eyes for a period of 1 week. After a period of 1 week, they are allowed to do almost everything as they were doing before surgery. Today, we have available with us multifocal lenses which are able to focus light from different distances, and once implanted these lenses, the patients are available to carry on with almost all their normal activities, whether it's driving, watching TV, working on computers, or reading without the need for external glasses, because of which the patients are able to enjoy the kind of vision that they never had during their lifetime. We also have available with us the toric intraocular lenses, which apart from correcting the sphere are also capable of correcting the cylindrical power in the lens. and a combination of toric and multifocal lenses are also available. These foldable lenses go through a very small incision, because of which these incisions are self-sealing and no sutures are necessary. Today at the Eye Foundation, we also have available with us the laser cataract technology, where most of the procedure is carried out with laser precision. The size of the incision, the size of the capsular rhexis, the exact location is essentially fed by the surgeon onto a computer. The laser fires exactly where it is meant to create these openings, so that the surgeon just had to open them up and subsequently implant an intraocular lens after removing the opaque lens material. Because of this extreme precision, the kind of visual rehabilitation that these patients get, or restoration to almost near normal vision, happens in 99% of the cases almost in the immediate post-operative day 1. Today, cataract surgery is a simple surgery as it is being performed at the Eye Foundation, without the need for the patients or his attendants being put to significant trouble or variation from their normal routine. All of them can get back to their normal routine with excellent visual recovery, with minimal reliance on glasses, almost from post-operative day 1.
Glaucoma as a disease is a second leading cause of blindness. To understand the enormity of the disease, if I could just reel off the World Health Organization statistics, it says that as of date, 4.5 million people are blind from glaucoma disease, and 60.5 million people world over are suffering from glaucoma. So look at the enormity of the numbers, and that tells us that this disease has to be diagnosed as early as we can, so that we could ensure that the patient has a life where he could visually manage with this task, even in this kind of a dreaded disease. What we also need to understand about this disease that is it's a silent killer. It's asymptomatic, excepting in a particular segment of population whom we call them as angle closure attacks. In this disease, being a silent killer, the patient is totally unaware that he has got the disease in his eye, and it is only in the advanced stage of the disease, when the disease starts gradually making the patient lose his vision from the periphery to the center, and he comes to a near tunnel vision with a major handicap in his day-to-day activities, which is when he would come running to the doctor if he is to understand the symptoms. So it becomes necessary that glaucoma as a disease be evaluated as a routine component of evaluation. And who are the patients who are going to be afflicted by glaucoma? A person could be born with a glaucoma, like a child could have a congenital glaucoma, wherein the parents may not be able to diagnose it because it could be asymptomatic, or it could present with a very large eye, or it could be a watery eye, or the child would be not able to look at light, or which is called as photophobia. And when the parents take the child to the pediatrician, and who refers him on to an ophthalmologist. Or it could be a disease which is more commonly seen above the age of 40, wherein it could be associated with the family history, wherein genetically the disease is passed on as a hereditary disease, or it could be because of steroid intake. So a person, besides undergoing eye examination, a vision check, it's important that every single patient undergoes an intraocular pressure check, and on a slit lamp evaluation we decide what is the chamber depth. Now, why measuring the chamber depth becomes important is there are this segment of people who have a narrow anterior chamber depth, and when you notice that a person has a narrow anterior chamber depth, you should be thinking of a narrow angle glaucoma. So then, it is something which is picked up in a routine eye examination. The other very important take-up is called the measure of the intraocular pressure, which is done by the gold standard of applanation tonometry. There are other ways of measuring the IOP, but the gold standard is an applanation tonometry, wherein you are able to measure the intraocular pressure of the eye. And when there is a suspect that it is not within the narrow normal range, then you immediately, it sensitizes you that there could be a possibility of glaucoma. Then you delve further into the history of the patient, asking whether there are any family members who are afflicted with the disease, or there's an injury, or there is some intake of drugs which could coexist with this disease. And when there are certain clinching issues which is there, even just a solitary stand of a raised intraocular pressure itself would mandate that you go on to the second step. Then you would advise the patient that there is a suspicion that there could be a disease lurking somewhere. So you would take them to the field analyzer, which comes as different machines. We have the Humphreys or the Octopus field analyzer, wherein you are able to do a measure of the field of vision of the individual, because this glaucoma as a disease, it's the pressure, intraocular pressure of the eye, which tends to get raised and starts pressing on the optic nerve, or the very important nerve of the eye, and gradually it starts killing the neurons of the eye, and gradually there's a constriction in the field of the vision to becoming narrow and narrow to a tunnel vision to ultimate blindness. Armed with the information provided by the field analyzer, the OCT and the optic disc evaluation and the fundus photograph, you are able to conclusively decide that yes, this patient has a glaucoma disease. Once you have diagnosed the glaucoma disease, it becomes very important that you counsel the patient. This untreated, this would gradually completely take the vision out of the individual. So we need to be aggressive and immediate in our management strategy, which could be a medical management or a surgical management. All in all, what I would like to conclude saying that this is a disease where one needs to be very wary of, and if you're able to take care of this patient at the early stage of the disease, or even in a moderate stage of disease, you could keep it in good control and manage to maintain the quality of the life of the individual for any number of years.
India is home to almost 7.5 million people who are blind due to corneal diseases, and WHO estimates that by 2020, we will have 10 million people who are blind due to corneal diseases, and most of which are avoidable with a well-done corneal transplantation. About 1.5 million people are bilaterally blind because of corneal diseases. We perform only about 20,000 corneal transplants in India annually, and therefore you can see that there is a huge burden or backlog of corneal diseases which we need to attend to urgently. Unlike the kidney and liver transplants, which are highly vascular organs and are prone to rejection because of the increased blood supply in those organs, the cornea is relatively avascular and is almost devoid of any blood supply. Because of this, the success of corneal transplants is as high as 90 to 95%. The recovery from corneal transplants is also very quick and does not require any long-term systemic medication in the form of tablets, unlike other organ transplants where the tablets itself have a lot of side effects. These drops are simple to use, easily applicable, do not have any long-term side effects, and can really prolong the life of the graft in that particular individual. We are now even able to proceed towards component corneal surgery, which means to say that the cornea has 5 various layers, and there are several diseases which affect only one particular layer. So we are now able to replace only that particular layer which is affected in that particular individual, and therefore increase the success rate of corneal transplants. For patients who are bilaterally blind due to corneal diseases and are at high risk for a routine corneal transplantation, we are now able to perform a procedure called keratoprosthesis, which is basically an artificial cornea which can be placed in a patient's eye to give them a very good visual recovery, but at the same time alleviating the risks of rejection in a routine corneal transplantation. We at the Eye Foundation are completely invested into the goal of eradicating avoidable corneal blindness through our Eye Foundation Eye Bank, which provides us with numerous corneal tissues to perform the necessary transplants. So I would request one and all of you to pledge your eyes today to help millions see the world tomorrow.
Keratoconus is one of the commonest corneal condition. Nowadays we see almost 10 cases out of 100 patients with refractive errors. It has become very common. It's nothing but abnormal bulging of the cornea, and it's called conical cornea. There are various reasons for this keratoconus. It could be because of eye rubbing. This is one of the commonest cause, and it could be because of some other environmental factors, or it can even run in families due to genetic predisposition. And the patient can have a progressive loss of vision due to abnormal reflection, and this condition can be treated by different ways. So it actually in the initial stages we can manage these cases with glasses and then contact lenses, and if it progresses, if the patient is not able to tolerate contact lenses, next we have to do other procedures to improve the visual acuity. If it progresses to an end stage, then in such cases we have to do corneal transplantation, which can be either a lamellar keratoplasty or a full thickness keratoplasty. And if we detect this in the early stage, we can stabilize the condition by doing what is called corneal collagen cross-linking, that is C3R, which actually stabilizes the condition, which strengthens the cornea and stabilizes the condition. It prevents further progression of the condition. It will not improve the visual acuity, but for vision the patient needs glasses or contact lenses. And even in the contact lenses we have various advances that has taken place in the last couple of years. We can fit a rose-K lens, or we have a hybrid lens that's called soft perm lens, and the quality of vision is much better in these lenses, and comfort level is also much more compared to the regular lenses which we used to prescribe.
சர்வேஷ் வந்து பிறந்ததுலேருந்தே மார்கண்ணோட உடம்பு முடியாமல் இருந்துச்சுங்க. பார்க்குறது வந்து சைடாக தான் பார்ப்பாங்க. ஆனால் வந்து ஐ கண்டிஷன் வந்து பார்த்ததுக்கு பிறகு இப்போ வந்து டாக்டரெல்லாம் பார்த்ததுக்கு பிறகு என்ன சொன்னாங்கன்னா வந்து ஆப்ரேஷன் பண்ணிங்கன்னா கரெக்டாகிருங்க, நார்மலாக பார்ப்பாங்க அப்படின்னு சொன்னாங்க. ஆனால் வந்து நாங்கள் இங்கே ஆப்ரேஷன் பண்ணதுக்கு பிறகு வந்து இப்போ வந்து பையன் வந்து கரெக்டாக பார்க்குறான், பார்வையெல்லாம் நல்லா பார்க்குறாங்க.
Children are a unique entity. You cannot treat them as small adults. They need specialized eye care. So let's talk about refractive errors and lazy eyes in children. Refractive errors are not like refractive errors in adults. They need to be corrected in time, and they need to be corrected fully. If we do not do that in children, they would lose vision. They would develop what is called a lazy eye. It's a common misconception among parents that once you give them glasses, they have to continue using it for life. That may be so, may not be so. Sometimes we give glasses for improvement of vision. Sometimes we give glasses to relieve eye strain. Let's understand why glasses are so important. Consider the eye as a camera. Unless the lens and the photographic film are in correct alignment with each other, you would not get a clear photo. If the lens is canted to one side, you would get a photo that is fuzzed. If the film is not located at a proper distance from the lens, you would again get a blurred photo. Consider the eye as a biological camera. The retina, which is the photofilm of the eye, has to be at a perfect distance from the crystalline lens of the eye. If that does not happen, you get what is called a refractive error. This refractive error leads to a blurred vision. Blurred vision in turn leads to an improper connection between the eye and the brain, especially in children less than 8 years of age. These children tend to develop what is called lazy eye or amblyopia. If we do not give them glasses in proper time, they would end up having poor vision for the rest of their life. Now let's come to a less serious situation. They do have a refractive error, but they are not using or wearing the glasses, or they are not aware of the same. This could happen because children are not small adults. They would not complain. Instead, what would happen is that they would try to go closer to the board, or they would lose interest in studies. They may develop eye strain, they may complain of headaches, they may develop frequent attacks of red eye. So how do we diagnose refractive errors in children? Older children may complain. Children who are born premature need to be routinely screened at around 1 year of age. Children of parents who have high refractive errors also need to be screened. And all children should have at least one eye examination by a pediatric ophthalmologist before the time they enter school. That is around 3 to 4 years of age, before the time they would go to play school or preschool. They need to have an eye exam by a qualified pediatric ophthalmologist. This would help us ensure that none of these kids who need glasses are deprived of them. Cataracts in children can be quite serious. They can occur as early as 3 to 4 weeks of age when they are called a congenital cataract. Sometimes they may be present at birth. Unless we operate on them early, they would be deprived of useful vision for the rest of their life. So how do we treat cataracts in children? Surgery is the only option for pediatric cataracts. We have modern equipment, we have modern anesthesia techniques. This permits us to operate on children as young as 4 to 6 weeks of age. We also have modern intraocular lenses, and we are able to implant intraocular lenses in children as young as 6 months of age. For children who do not receive an intraocular lens, we have excellent glasses for them. But believe me, if you do not get the child to a pediatric ophthalmologist on time, you have already missed the bus, and there's little that we can do to improve vision. So the only solution for treating pediatric cataracts is get them early to a pediatric ophthalmologist and ensure surgery at the earliest. Ocular infections occur very commonly in children. Most often these children come with conjunctivitis. The conjunctivitis, or Madras eye as we call it, spreads very rapidly among children, primarily because of poor hand hygiene. So it is a misconception that the conjunctivitis or Madras eye spreads between children merely by looking. It spreads usually by sharing towels, handkerchiefs, and also by what we call as in the medical jargon as fomites. Fomites merely mean objects. For example, if a child is infected with conjunctivitis and he or she touches a book, the other child also touches the same book and rubs his or her eye, then the virus, the conjunctivitis is most commonly caused by a virus. The virus would spread from one child to another. So these outbreaks of conjunctivitis are very common in public places, in hostels, and also in schools. So the emphasis should be on hand hygiene. Children less than 1 year of age, please make sure that whoever handles them washes his or her hands properly with either hand sanitizer or with soap before handling these children. Once again, abuse of steroids should be avoided in conjunctivitis. It is recommended that you use medicines only on the advice of a pediatric ophthalmologist. Never purchase it from the medical shop and use, and also only for the time that has been recommended. So whenever your child develops a squint, you have 2 or 3 bad things that are going on. One, of course, is the cosmetic blemish that the child would face in school. The second is that binocularity or three-dimensional vision is gone. The third is that if you do not treat squint or strabismus, you run the risk of developing a lazy eye. Now consider that you have a child who has his or her left eye squinting. So over a period of time, what the child's brain would do is that the child's brain would get locked onto the right eye, will start ignoring the left eye, and the left eye would gradually start losing vision. So how do we treat strabismus? So that is important, because only a qualified pediatric ophthalmologist can treat strabismus to its fullest. For some children, they do very well with glasses alone. For some, we give patching. By patching, we start covering the good eye with a skin-friendly sticker. So this improves vision in the left eye. It may bring the deviating eye into alignment. For others, we have strabismus surgery. Now, once again, when I mention strabismus surgery for squinting in children, parents give a reaction of shock. My child, does it have to be surgery? I mean, after all, it's considered as a sign of good luck, but I have already explained why it is not so. Strabismus surgery these days has become very safe with the advent of excellent anesthesia equipment and personnel. So operating on these children means that your child is not going to have any pain. The eye could be sore for a day or two. And whenever I operate patients on a Friday, I usually pack them off to school by Monday or maximum by Tuesday. So bow and arrow injury by either custom-made bow and arrow or whatever is available in the shop should preferably not be given to children, or if at all the child has to use it, should only do so under adult supervision. And they should never have any arrows with sharp edges on them. So this very often is forgotten, and this bow and arrow injury, unfortunately, sometimes bows and arrows made from a broomstick, the broomstick has all the bacteria, all the dirt from the house in it. So whenever it hits the child's eye, it could transmit all kinds of the bad bacteria into the child's eye, and your child could end up losing vision. For the milder forms, they may develop what is called a cataract. The severe forms of bow and arrow injury can end up with endophthalmitis, which is an infection of the eye, which could essentially eat up or completely destroy your child's eye. The other reason why children get injuries is use of firecrackers without adult supervision and without protective eyewear. I would recommend that all children, and for that matter all adults, should use firecrackers only after wearing protective eyewear, and all children should do so only under adult supervision. Keep all harmful chemicals and tuna, etc. out of the reach of children. Sometimes we do get children who have literally burned their eye because the tuna that they were trying to open, the tuna that is used on pan one that they were trying to open accidentally spilled on the child's eye. So these are three common ways in which children can get injury, and the most unfortunate thing is that even though these are perfectly avoidable, the parents hardly understand the seriousness until his or her own child gets it. And if your child does happen to get an eye injury, please do not attempt to do anything yourself. It's better that you get them to the attention of a pediatric ophthalmologist at the earliest. And further, if your child has a chemical injury, wash the eye with copious amounts of tap water or whatever water you can get. Please make sure that it is washed before the child comes to the attention of a pediatric ophthalmologist. If you do that, and if you get these children to a pediatric ophthalmologist at the earliest, you may end up preventing a child's vision loss. Remember, if an adult loses vision, there are only so many years he's going to live. But if the child loses vision, the child has to be visually impaired for the rest of his or her own life. And when it is an avoidable injury, please do attempt to avoid it.
என் பேர் நாகராஜன். நான் வந்து 2.5 இயர்ஸ்க்கு முன்னால் இங்கே வந்து அந்த டோசிஸ் கரெக்ஷன் ஆப்ரேஷன் பண்ணிட்டேன். மெயினாக வந்தது இப்போ டிரைவிங் லைசன்ஸ் எடுக்க முடியல என்னால். ஒரு கண் கம்ப்ளீட்டாக ஹாஃப் அளவு க்ளோஸாக இருந்ததுனால அந்த விஷன் கரெக்டாக இல்லை அப்படின்னு சொல்லிட்டு ஈவன் 2-வீலர் லைசன்ஸை ரினியூவ் பண்ண முடியல. சின்ன வயசில் எடுத்ததை 50 இயர்ஸ் வர்றப்போ ரினியூவ் பண்ணணும் அந்த இதில். அப்போவே வந்து பயந்து தான் ஓட்டிகிட்டு இருந்தேன் லைசன்ஸே இல்லாமல். அப்புறம் தான் இந்த ஆப்ரேஷன் பண்ணவொன்னே லைசன்ஸ் எடுத்துகிட்டு 4-வீலர் லைசன்ஸ் எடுத்துகிட்டு இப்போ நான் கம்ஃபர்டபுளாக நான் ட்ரைவ் பண்ணிகிட்ருக்கேன்.
When this gentleman, Mr. Nagarajan, presented to me with a droopy eyelid which covered almost half of his eye, creating problems like driving license acquirement and day-to-day problems, what I did basically was a simple ptosis surgery which made a wonderful change in his life. So I get to see many patients presenting to me with eyelid abnormalities. Basically, some of these patients can have a droopy eyelids, some might have an eyelid which is turned inwards, some outwards, creating problems for them. It's a cosmetic blemish most of the time, and patients seek treatment for cosmesis or sometimes like this kind of practical difficulties. So we do have a wide range of surgeries which could correct these kind of abnormalities. And I also treat some of the patients presenting to me with lacrimal disorders. So these patients will have constant tearing from their eyes. Some of them have discharge constantly, and many patients do develop some kind of infection around the eyes. So all that requires is a good assessment and a surgical correction that will fix the problem forever. And I also treat some of the orbital disorders. Basically, orbit is a bony wall that surrounds our eye. Our eye is housed in the bony wall which we call as orbit. So this orbit has got the muscles which moves the eyes, also the nerves and the blood vessels and fat. So there are problems which can arise from any of these structures that I mentioned, like muscles, nerves or blood vessels or the fat. So I do treat all those conditions, and we do have a wonderful exclusive orbit prosthetic center which deals with providing prostheses for the patients who presents with painful blind eye. So the patients who had lost their eyes is an unfortunate incident, but what we cannot give back is a vision, but what we can give is a matching eye that looks and moves like the normal eye. So this is what we do here in the orbit and oculoplasty department.
Retina is the most important part of the eye. This layer is responsible for having good vision. The innermost layer of the eyeball is known as the retina. This innermost layer gives you good central and peripheral vision. Sometimes when this retina develops a tear or a hole, the central fluid communicates through this retina tear or hole and seeps through it and gets underneath the retina, causing a devastating condition known as retinal detachment. This, when it happens, the patient experiences sudden vision loss, which starts usually in the periphery and then moves slowly to the center. This is often associated with multiple flashes of light and floaters. When patient experiences such symptoms, he should immediately report to an eye doctor or a retina specialist nearby. Then the doctor examines him under dilatation using a dilating drop, and using complete indentation and the indirect ophthalmoscopy, the doctor studies the retina and looks for the tear and the hole, and establishes the diagnosis of this condition known as retinal detachment. With modern technology, we have various minimally invasive techniques known as 25 gauge vitrectomy and 23 gauge vitrectomy and 27 gauge vitrectomy, where we use the appropriate method to rectify this problem. The other modalities of treatment are scleral buckle and pneumatic retinopexy. So patients need to be aware of these symptoms, that is flashes of light and floaters appearing in your visual field. When there are more number of floaters or flashes of light, and if there is a symptom, something as curtain falling and in the peripheral field of their vision, they should immediately report to a doctor. And if there is a retinal detachment, your doctor will inform you and it will be duly attended.
Basically, any patient who has diabetes is susceptible to developing diabetic retinopathy. So it doesn't matter if the diabetes is well controlled or not. The patient with normal vision and well controlled diabetes also can develop diabetic retinopathy. So initial stages, when the patient presents with no symptoms and comes for a regular checkup, it may be a minor trivial things like refractive error or cataract, which can be easily tackled. So initial stages also, diabetic retinopathy can be seen where it can be not causing any visual symptoms. So when the visual symptoms arise, actually the disease is already advanced. So when the patient comes as a routine to us just for an eye examination, we dilate the pupils and check his fundus to look for diabetic retinopathy changes. And when these changes are seen, we advise the patients to have a regular examination. Even if the fundus, if the retina is normal, we still need to have a regular checkup in spite of a well-controlled diabetes. So when these symptoms arise, patients have undergone through the investigations, and then we subject these patients to certain treatment modalities. Most common treatment that we offer the patient, depending on the disease level and severity, includes laser photocoagulation, intravitreal injections, where injections are given into the eye. So intravitreal injections given in the eye are basically a short gap treatment to control the disease and not a cure. So there may be repeated sessions of this treatment that may be needed. When the patient comes after in a very advanced stage, sometimes we need to take up the patient for surgery, retina surgery, which is a different surgery from cataract. Where the disease has advanced to so much that the intravitreal injections and lasers are not able to control the problem. In such cases, we need to go in the eye and remove the blood and all the offending factors which are causing vision impairment. All said and done, it is always better that we heard about the saying called prevention is better than cure. So whenever possible, we should be able to prevent the disease. That's the first step. And whenever the disease has advanced to a certain level, it's always better late than never. So even if the disease has advanced, we still try to resolve the disease and help to stabilize the vision, and in certain cases help improve the vision as well. But even if everything is lost and vision is lost, there are still certain stages where we may have to stabilize the vision and prevent further loss. So each of these treatments may vary, and the treatment may differ from one patient to the other. It is not a kind of a uniform blanket treatment as like cataract surgery, and each treatment needs to be customized based on the patient's need and the level and severity of the disease.
Optometry services play a very key role in our patient services. Optometry relates to all eye measurements. Whatever measurements we deal with the eyes is related to the optometry department. We have subspecialties like orthoptics, contact lenses, dispensing, and general patient care. Orthoptics means is something related to the muscle evaluation. any patient coming to us who has some eye-related headache, eye tiring symptoms, especially patient who works on computers or who are into development and who are into a lot of intrinsic work as far as their eyes are concerned, get eye-related, muscle-related problems. This department purely deals with the muscle-related diagnosis and management. Next is contact lenses, where we deal with different type of contact lenses which are customized to patient's requirement. There are a variety of contact lenses we dispense with, including specialty lenses like scleral lenses, rose-scale lenses on a routine basis. Other subspecialty is our dispensing unit, where we optometrists and the optical services coordinates each other, and we have a very close coordination between the optical services and the optometrists, ensures 100% scientific or spectacle dispensing. When we talk about scientific spectacle dispensing, generally a patient takes a frame and they fit a lens and then that's it. So actually fitting a lens into the frame has to be scientifically measured, fitted. So there are different steps and different protocols we follow, where we have a close coordination between the dispensing optician and the optometrist.
Thank you so much for choosing the Eye Foundation group of eye hospitals for your eye care needs.